So first, coming to the patient evaluation, the evaluation of a complete denture patient or a partial denture patient for that matter starts when the patient walks into the operatory or into the department. This usually involves the following, that is, we examine the gait, the age, the expression, the complexion, speech, even the breathing pattern, personality, as well as mental attitude of the. Now, first, coming to the gait of the patient. Most of the complete denture patients seeking treatment are old or middle-aged patients. By observing the walk of the patient, the steadiness of the walk, and the coordination gives us an insight into the motor skills of the patient and evidence of any systemic disease. Stooped shoulder may indicate spinal changes or spinal atrophy. Tremors of the head and hands and feet may be indicator of Parkinson's. When a patient is dragging one foot in front of the other, it is indicative of a stroke and will be elaborated during the history taking. Staggering may indicate excessive alcohol consumption or patient may be on antidepressant or heavy medications. Coming to the age. Here by age we refer the physiological age of the patient and it gives us information about the patient's expectations. A young patient who appears indifferent or disinterested may be a difficult patient for the complete denture acceptance, whereas an old patient who appears young may indicate the willingness to adapt to the treatment and look good. So this is a good thing for the success of a complete denture treatment. Now coming to the facial expressions. Facial expression give us vital information about the mental attitude and the presence of any disorders. Lack of facial expressions may indicate lack of muscle tone. It may also can also be due to trigeminal neuralgias or plastic surgery, as you can see over here. Now, coming to the speech of the patient, the fluency and quality of speech of the patient should be noted, especially if the patient is wearing existing or old dentures. If the speech is altered, this could either be due to the poor denture construction in the old denture or due to the lack of vertical dimension or due to the wear or breakage of the teeth, and this should be noted and should be rectified in the new processes. Speech may altered be due to hypernasality or due to hoarseness of the voice, which may indicate paralysis of the vocal cord or excessive smoking. Now, coming to the breathing pattern, generally old patients have difficult breathing and it may be manifest itself as heavy sighing, wheezing, which is indicated of asthma. Shortness of breath is also seen in denture patients, which may indicate lung disease like tuberculosis, fibrosis, and it may be indicative of the previous heart failure or congestive heart failure. Shallow breathing may be indicative of pulmonary fibrosis, which may be due to excessive smoking. Now coming to the mental attitude, all these things which I'm talking about come under patient evaluation. So House divided the patient's mental attitude into four categories, that is philosophical, exacting, indifferent, and hysterical patient. A philosophical patient is one who is rational and composed of difficult situations. He is an educated patient and understands the limitations of the treatment and understands why he is seeking a treatment. They desire treatment for the maintenance of health and their appearance. They learn rapidly and they have the best mental attitude for the acceptance of the complete denture. Next, in contrast, the exacting patients are very methodical, they are precise, accurate, and they make severe demands, sometimes unrealistic. These patients often have OCD. They are comfortable when each procedure is explained to them and discussed with them beforehand. They require extreme care and they may be difficult patient for certain dentists or young practitioners, and they should be handled with care. When they are handled with care and each procedure is explained beforehand and each step as being informed, then these patients become very cooperative and they also are some of the best patients when it comes to the acceptance of a complete denture treatment. Whereas an indifferent patient, these are patients that do not have any concern or motivation towards a dental treatment. They are usually undergoing or coming to you for complete denture treatment because they are being forced by their family members. So these type of patients present a questionable or an unfavorable prognosis. The last mental attitude is hysterical. These patients are emotionally unstable, they are apprehensive, they do not trust anybody, they have certain mental issues that you must be aware of, and they also have certain systemic health issues. They often present an unfavorable prognosis, and additional psychiatric counseling is required prior to the beginning of the complete denture treatment. Now, coming to the history, diagnosis, as I mentioned, involves three parts, that's patient evaluation and history. So, coming to the history, it is recorded It is a record of all the information which is obtained from the patient, and these must be kept for further reference and later use. Health history is extremely important for the patient's overall diagnosis and treatment plan. It is obtained by a combination of questionnaires and direct interrogation. So, history involves three aspects. First is the general history, the second is the past dental history, and third is the patient's past medical history. Coming to the general history usually informs the regular information that we use to fill forms such as name, age, the sex of the patient, occupation, his address, whether he has any habits like smoking, pan chewing, or any other parafunctional habits such as masochistic habits, how is the patient's nutritional history, whether it is adequate or the patient is malnourished. This gives us an idea of general idea of the patient's status and will help indirectly in the treatment plan. Next, coming to the medical history. Now, medical history is very important and consists and is very broad, but here are some of the things that need to be considered before the fabrication of a denture. These may include debilitating diseases like diabetes, joint disorders such as rheumatoid arthritis or osteoarthritis, cardiovascular diseases like MIs, anginas, and any cardiovascular procedures such as bypass surgery that have been done in the past, neurological disorders such as Parkinson's, Bell's palsy, or if patient has any oral cancers or may be showing signs of and symptoms of any oral malignancies, whether patient has a history of epilepsy and is on anti-epileptic medication, whether there are any skin diseases that have oral manifestation and may affect the success of the complete denture treatment. In case of females, whether patient is has reached menopause or not, and lastly, medications that may interfere with the systemic conditions and also as well as salivary flow of the patient. First was debilitating conditions. One of the most common debilitating conditions seen in the dental clinic, especially in prosthodontics, is diabetes. Often, most of the times, patient has lost his teeth because of uncontrolled diabetes or poorly controlled diabetes. They have higher risk of opportunistic infections like Candida albicans and denture stomatitis or denture hyperplasia. In such patients, salivary flow is also impaired, worsening the overall prognosis and success of the treatment. So these issues need to be addressed beforehand. Other conditions such as tuberculosis is very contagious, and patients should undergo long-term anti-tubercular medications before beginning the treatment. Other conditions like blood discariasis require specific precautions if pre-prosthetic surgeries are contemplated or planned, and these should be addressed as the mucosa is very fragile and sensitive to dental pressures. Here is a mucosa showing denture stomatitis and is very inflamed. Now, coming to the disease of joints such as arthritis, rheumatoid arthritis, and osteoarthritis. These are very common and they often affect the fingers, the elbow, and the shoulder joint of the patient, making it difficult for the insertion and removal of the dentures as well as cleaning of the dentures. In such cases, patients may be advised to get a full-time carer to do all these things. When the temporomandibular joint of the patient is affected by arthritis, it may result in restricted mandibular opening, pain in the TMJ, and the deviation, clicking, crepitus of the joints. In such cases, recording maxillomandibular relationship, taking primary as well as secondary impressions becomes difficult. So we may need to fabricate customized sectional trays such as the ones shown over here, because a regular stock tray or a regular custom tray will not fit inside the patient's mouth due to restricted mouth opening and pain in the TMJ. Also, sectional record bases may need to be fabricated for recording the maxillomandibular relationship. Now, coming to the cardiovascular diseases. Now, usually stable cardiac problems do not interfere with the complete denture treatment and are of little concern. Getting informed consent or a clearance from the cardiologist usually takes care of the problems. What we need to take care is that we should have short appointments for such patients who have cardiovascular disease as well as diabetes. We should schedule early morning appointments for these patients when the operator is free and the patient does not have anxiety. These patients need to go to the bathroom regularly, most often like diabetic patients, and cannot handle stress. So appointments should be kept short, and early morning appointments are preferable. If the patient is on anticoagulants such as clopidogrel, clopidogrel, these need to be stopped in case any pre-prosthetic procedures are planned beforehand. Next, coming to neurological conditions such as Bell's palsy and Parkinson's disease. These patients usually present problems not only during the denture construction but as well as the retention of the dentures because of the lack of the peripheral seal, poor neuromuscular control, which may affect the denture stability. So, in such cases, adjunctive things such as denture fixatives may be required. So, next is the oral malignancies. Now, construction of a complete denture may be commenced depending on a tumor prognosis. That is, if the patient has pre-existing oral condition or oral malignancy, these need to be treated before the fabrication of the complete denture. Also, we have to keep in mind that when patient comes after the treatment or after the surgical procedure, he may be missing a part of the tongue. That is, hemiglossectomy may be done in case of the lingual carcinomas. He may be missing a part of the jaw, like hemimandibulectomy or partial mandibulectomy. The buccal or lingual vestibules may be obliterated, and the tissues will be very fragile and very friable and sensitive to the denture construction, as well as the retention of the denture will be compromised. So in such cases, overdentures or implant supported fixed or removable dentures should be considered. Also, patient should be recalled regularly to see if there is any evidence of the radiation necrosis. Coming to epileptic patients, these epileptic patients as such do not present any problem, but which should be borne in mind that in case of an epileptic seizure, patient may break and then may aspirate his complete denture or a part of the complete denture. Therefore, selection of an appropriate denture-based material before the fabrication of denture is very important. In such patients, either traditional cast room cobalt based complete denture or dentures with the fiber reinforced resin or unbreakable resin dentures such as polyamide and valplast should be considered for the fabrication of the denture. Now, coming to disease of the skin that also have oral manifestations such as pemphigus and epidermolysis bullosa, these may manifest as ulcers and bullae within the oral cavity. Therefore, medical treatment may be required and it may or may not provide relief to these patients. The constant use of dentures in such patients should be discouraged, and if possible, dentures with soft liner or soft tissue conditioners should be fabricated for the patient. In postmenopausal women, there may be concerns about conditions such as osteoporosis, burning mouth syndrome, migratory glossaritis, and also mental disturbances may be seen ranging from mild irritability to complete nervous breakdown. They may also require psychiatric counseling and medication to further the treatment. Now, when old patients come to your clinic, most of them are on several medications. They may be on anticoagulant, they may be on antihypertensives, such as alpha blockers, beta blockers. They may be on other medications that may affect the salivary flow and may result in xerostomia or thick ropey saliva. In such cases, adjunct substitutes such as xylem melts, xylitol sprays, and xylitol chewing gums may be given to the patient to promote salivary secretion and to reduce the effects of the xerostomia and make denture wearing more bearable for such patients. Also, dentures with reservoirs such as this, you can see a maxillary denture which has a reservoir in the palate with a soft silicone lid over it, are filled with artificial saliva to provide a slow, sustained salivary release throughout the day for the patient. Now, coming to the dental history. Now, dental history consists of the past dental history, whether the patient is wearing current dentures and what is the condition of these dentures, the patient's pre-extraction records, if any are available, and if any diagnostic casts are available. These all offer us a key insight into the patient's dental history and what needs to be done to address any issues that may be pre-existing. Now, the past dental history, first thing to be noted is what was the reason of the bone loss, whether it was due to periodontal disease or whether it was anticipated, and it also helps us in the prognosis. The period and sequelae of the edentulism is also very important. The longer the patient has been edentulous, the more will be the bone loss, and the less compliant the patient will be to accept the complete denture treatment because he has already been edentulous for a long time. He's not wearing dentures, so getting a denture to patient to become comfortable to new dentures is pretty difficult. Whether previous dental and denture experience. Usually, if patient is a denture wearer, it is easier for the patient to adapt to the treatment because he has been wearing a denture. But if the patient has had traumatic experiences with previous denture or previous dental treatment, this may require counseling, as he may not be a very adaptable patient. It also gives us into insight of the patient's attitude, his desires, and their expectations. Next, coming to the current dentures, that is the old dentures or existing denture which the patient is wearing. Usually, these should be examined for vestibular extensions, the vertical dimension, whether there is any loss of vertical dimension due to attrition of the teeth, whether the relation and centric occlusion match, or whether there is slide in centric. Usually, in old dentures, the centric occlusion relation will not match because of the severe attrition and wear of the dentures. Whether the artificial teeth are fractured or worn out, how is the retention, stability, and support, as well as aesthetics. So, because any of these issues will need to be addressed in the future denture. So we have to check whether the denture is attrited, whether there is broken teeth, whether the vestibule extensions are poor or they are sufficient, whether the denture hygiene is good. If the denture hygiene is not good, there's a lot of stains or calculus and tartar deposits on the denture base, then this is indicative of the poor patient maintenance and poor hygiene, and they need to be counseled before the fabrication of a new. Pre-extraction records such as diagnostic casts, radiographs, and photographs are very helpful, and they may give us insight into determining the patient's determining the vertical dimension, as well as the size and shape or mode of the tooth that need to be selected for the construction of a new denture, as well as the position and arrangement. Photographs also give us information on the tooth size, position, and the tooth display. How much tooth display should be there when the patient smiles. Now, coming to the examination part, that was the history. The second part of diagnosis is the examination. So, examination usually is again divided into three parts: extraoral, intraoral, and radiographic. External diagnosis usually involves the examination of the face, the lips, and the TMG. Intraoral examination starts with the examination of the mucosa, the residual ridge, the floor of the mouth, the palate, and the tongue. And finally, the radiographic examination involves mainly the OPG and the CBC. Coming to the first examination of the face, Leon William classified the face based on the shape of the face into four forms. They may be square, square tapering, ovoid. They may be square, square tapering, tapering, and ovoid. This shape of the or form of the face is usually important in selecting the shape of the artificial teeth, which would correspond with the facial form. Next, coming to the facial profile. Again, House classified facial profile into three categories, that may be a straight profile, a retrographic profile, which is known as a class 2, and a prognathic profile, which is known as the class 3. Again, this will help give us information about the not only the selection of the teeth mold, but how the arrangement of the teeth, whether the teeth need to be arranged in crossbite, in posterior crossbite in prognathic class 3 individual, whether the teeth need to be arranged in a cluster situation in retrographic mandible, or whether premolars need to be removed to get a proper class 1 relationship. So all these factors are helpful in the final success of the treatment. Now, coming to the examination of the lip, this again comes in external examination. We have to examine the lips for, that is, the commissures for angular cheilitis or canker, cold sores, that is herpes. So this is indicative of the any nutritional deficiencies such as vitamin D deficiencies, any secondary or opportunistic infections such as candidiasis in case of a diabetic patients, and is also indicative of the loss of vertical dimension. Now, coming to the lip support, lack of proper support can lead to wrinkling of the patient's lips, the philtrum, and the nasolabial fold. This is mainly caused due to the age, the health of the patient, and sometimes it may not be correctable with giving new dentures. So, patient should be informed beforehand what can be corrected and what cannot be corrected. However, needless to say, by proper placement of the anterior teeth, that is canine to canine, we can to a certain extent provide proper lip support. We can obliterate the nasolabial fold and remove certain wrinkles. So here we can see next is the lip thickness. In patient with thin lips, like on this figure over on the left side, we can see that the lip is hardly showing, and in such cases, placing the too far labally will result in the stretching of the skin over the lip and will compromise the aesthetics. Whereas in case of thick lips, they can tolerate the alteration of the tooth position more easily without any visible changes. Now coming to the length of the lip. Length of the lip affects the amount of the anterior teeth show, that is exposure of the anterior. Same way that in a natural dentition we have patient with no show of the anterior teeth and patient with severe gummy smiles due to the increased height of the maxilla. Similarly, in the denture patients also, depending on the length of the lip, it can be long, medium, and short, and it will directly affect the display of the teeth during smiling or during speech. Patient with shorter lip will expose all of their upper anterior teeth and much of the labial flange, whereas a patient with long lip will hide most of his teeth and a denture base. Coming to the third external examination, that is examination of the temporomandibular joint complex and its associated muscles. They should be examined for pain by palpation or asking the patient to do mandibular movements. The range of the opening of the mandibular movement, any deviation, clicking, crepitus should be noted. It should be decided if the CD construction will solve some of these problems associated with TMJ, and the same should be conveyed to the patient. This is how extraocular examination works: examination of the face, examination of the what do you call facial form, profile, examination of the lip, examination of the temporomandibular joint, as well as examination of the musculature. Now coming to the intraoral examination. Now intraoral examination consists of, as I mentioned, examination of the mucosa, the residual ridge, the palate, the lateral throat form, even the floor of the mouth, the tongue, tori, and as well as the saliva. Coming first to the mucosa. Mucosa should be examined if there is any redness, which would be a sign of inflammation, which could be due to ill-fitting dentures, due to smoking or systemic disease such as diabetes. It is important to eliminate and identify and eliminate the cause and allow the tissues to return to the normal before making the final impression for the patient for the denture construction. Whereas white patches or brown or blue pigmentation spots should also be noted, and if the cause is uncertain, a biopsy is in order. Now coming to the mucosa thickness. How is classified mucosal thickness into class 1, class 2, and class 3? Class 1 was a normal uniformly dense mucosal tissue approximately 1 to 2 mm thick. Class 2 was soft tissue having very thin investing membrane, and such soft tissues are very highly susceptible to ulceration, soreness, and make it difficult for the patient to adapt to dentures. A class 3 is excessively thick soft tissue investing membranes. It may be due to the flabby ridges or due to thick rolls of tissue on the crest of the ridge, and they may be needed to be removed prior to the denture construction. So, an intraoral examination was in mucosa, color of the mucosa. Next is the palate, the hard and the soft palate. Next, coming to the residual alveolar ridges. Residual alveolar ridges, first thing we consider is the arch size. Depending on the arch size, the tray is selected for taking the primary impression. A small, medium, or a large tray may be used. A large residual alveolar ridges usually has a good prognosis because it offers a large surface area for the denture basal seat. I think some of you must have read about the snowshoe principle. So usually a large denture bearing area is good for denture construction and a small denture bearing area is not so favorable. Now coming to the arch form. After arch size, we have to consider the form or shape of the arch. That is, it may be square, tapering, or ovoid. And this will ultimately affect how the artificial teeth are selected and how the artificial teeth are arranged on the denture bearing area. Now coming to the ridge contour. A ridge contour will ultimately influence the retention and the support of stability of the denture. Class 1 is that is pre-extraction, that is before extraction, what is the ridge form. Class 2 is immediate post-extraction. Class 3 is high well-rounded ridges. These are ideal for the denture retention as well as stability. Class 4 are knife-edge ridges, and class 5 and class 6 are depressed and low well-rounded ridges. Now these are not so good for the denture construction. The best class for the denture retention and stability is the class 3, high well-rounded ridges. Now coming to the ridge relationship, inter-ridge relationship and inter-ridge distance is very important. The interspace, that is inter-arch space, is noted at a normal dimension. So if you have sufficient inter-arch space, that is, this is ideal for denture construction. If we have excessive inter-arch space between the ridges, usually when there has been excessive resorption of the residual ridges, this will increase the weight of the denture, increase the vertical height of the process, and it will make it unstable. Reduced interspace again is will create speech difficulties, will affect the aesthetics, always, as well as it may cause soreness of the basal seat area. Now coming to the ridge relation, under ridge relationship, other things that need to be considered is the parallelism of the ridges. This may affect the denture stability, as non-parallel ridges will cause movement of the denture bases when the teeth occlude. Ridge parallelism may be parallel or non-parallel. Next is a positional relationship. This will again affect the teeth arrangement and denture stability. As the maxilla resorbs, the maxilla becomes smaller due to the morphology of the maxilla, and whereas as the mandible resorbs, the mandible becomes larger in size due to the morphology of the mandible. So this may result in a class 1, a class 2 which is retinographic, and a class 3 which is a prognathic. So this is how ideal ridge relationship should be. Class 1, this is a retrographic situation where the maxilla is big and the mandible appears smaller. This class 3 is usually severe. In severe resorption cases, we will see that the maxilla has reduced in size and the mandible has increased in size. That is, there is increase in mandibular circumference resulting in a retrographic relationship. So, in residual ridges, we consider first the size, the form, the ridge relationship, the parallelism of the ridges, the positional relationship, whether it is class 1, 2, 3, and also we need to consider whether flabby tissues, hypoplastic tissues are present or not. Other things in intraoral examination that need to be considered is the bony undercuts, in the anterior maxilla. Usually these will be present on the labial side of the premaxilla. Tuberosity undercuts may be present bilaterally or unilaterally. They may present as bulbous or pendular tuberosities and may be unilateral or bilaterally. We also need to examine the mylohyoid ridge, whether it is prominent and close to the ridge of the mandible, and we have to note the frenum attachments such as labial frenum, buccal frenums, as well as the vestibules and the floor of the mouth, whether it is normal or raised. All these will ultimately affect the extension of the denture base, basal seat area, as well as the retention and stability of the denture. Now, next thing after the mucosa, the ridges we need to consider is the hard palate. Now, hard palate, just like the arch shape, our arch form is divided into three categories. That is a U-shaped arch, which is the hard palate, which is the perfect and the most ideal condition for the construction of a denture. The second is the V-shaped or high palate, hard palate, which is usually the has the most poor prognosis in the retention of the maxillary complete denture. And the third is the flat hard palate, is usually seen in extreme ridge resorption cases. Now coming to the soft palate, based on the degree of the angulation the soft palate makes with the hard palate is again divided into three classes. Class 1 is the soft palate is almost horizontal or parallel to the hard palate and with an angle of less than 10 degree. This is the most favorable for denture construction and for placing the posterior palatal seal. The second is the class 2 palate. It makes 45-degree angulation with the hard palate, and in the posterior palatal seal we have limited tissue area to provide a posterior palatal seal. The class 3 is a severe 70-degree angulation seen between the hard palate and the soft palate, and it is the least favorable for denture construction as it allows the least tissue coverage. There will be a lot of movement of the soft tissue during the deglutition speech, and this will affect the denture retention due to the peripheral seal is compromised, and also results in gagging reflex in the patient. So, coming to gagging reflex, we have to examine or ascertain whether the patient has a gag reflex, whether it is mild or an exaggerated gag reflex. Because an exaggerated gagging can compromise the procedure, such as primary and secondary impressions. The cause of gagging may be again systemic, it may be psychological, or it may be physiologic. So again, the management will also be clinical, psychologic, or pharmacological. If a patient has excessive gag reflex, we may need to spray the hard and soft palate with the topical lignocaine. Patient may need to be trained to control his breathing and to keep take his thought elsewhere, that is away from the dental procedure. Depending on the gag reflex, it is again classified into three types. That is, class 1 is the normal, that is, patient does not have gag reflex. Class 2 is patient is hypersensitive, that is, even after palpating or touching the soft palate and hard palate junction, patient does not feel anything. And class 3 is hypersensitive, that is, even by taking a mouth mirror or a probe just near the palate makes him gag severely. Now, coming to the lateral throat form, I keep telling you guys that this is crucial in the in the basal sheet area of the denture, finally in the retention and stability of the denture. The retromyloid space may be partially or completely obliterated due to the tongue movements. This area is very critical for providing the lingual seal and the lateral stability of the dentures. Neil classified the lateral throat form as into three. That is the deep, which is the most ideal for a dental construction, as we can get high and deep lingual flanges with a S-shaped curvature going into to the retromyloid space and giving the greatest amount of stability. Class 2 is moderate, that is between class 1 and class 3. And class 3 is the shallow lateral throat form, that is when the patient makes any tongue movements, the entire lingual or lateral throat form is obliterated. So in class 1, when operator places his index finger into the lateral throat form and asks the patient to protrude his tongue forward or to lick the upper lip, his finger is not pushed outside. Whereas in a class 3, that is the shallow lateral throat form, the operator's finger is completely or partially pushed out of the lateral throat form due to the obliteration of the lateral throat area. So this needs to be kept in mind. Now, coming to the tongue size, usually the size of the tongue it may be either normal, large, or small. When the patient has been edentulous for a long time, because there is nothing stopping the tongue is generally large or increases in size. So this creates problem during the as well as the procedures for denture construction, such as impression making, such as jaw relation, and it will also affect the stability of the denture. So next is the position of the tongue. What position the tongue is when the patient keeps his mouth open at rest. The class 1 is the tip of the tongue is just below the incisal edges of the mandibular anteriors, and the floor of the mouth is not raised. In class 2 also the tip of the tongue is just below the incisal edge of lower anteriors, but the tongue is broadened and flattened and the floor of the mouth goes down. This will create problems in the peripheral seal. And the class 3 is when the tip of the tongue is retracted back into the body of the tongue, and this will is the least favorite and will result in the instability and poor retention of the mandibular. So next is tori. If there are any exostosis or bony prominences present in the mandible or in the hard palate, they should be examined. Torus have extremely thin mucosa covering them, and they may get traumatized during impression making. Therefore, adequate relief should be provided. As I tell all of you, please provide double spacer relief for the tori. And this is very important because since the time for the past 3 weeks I have been in Penang, I've seen that around 60 to 70% of the patients have unilateral or bilateral tori in the mandible as well as a palatal tori. So this needs to be kept in mind. So Examination of palate, as I mentioned, involves the examination of the hard palate, the soft palate, the gag reflex, and then we have the examination of the lateral throat form, the tongue, any tori, and the last is the salivary flow. Whether the patient has excessive or reduced salivary flow or no salivary flow, as in xerostomia, what is the quality of the saliva, whether it is thin and serous or it is thick and ropey. Thin and serous saliva is conducive for denture retention and peripheral seal, whereas thick ropey saliva will result in poor retention and soreness of the basal seal. Lastly, coming to the radiographic examination. Radiographic examination is usually done to see if there is any pathology such as retained root or impacted or unerupted teeth within the body of the mandible or the maxilla, and that may be associated with tumors or cysts such as dentarious cyst, ameloblastoma, or there are any TMJ disorders. These may need to be addressed depending upon the how critical it is. The amount of bone resorption that has happened can be assessed by a method given by Weichel and Scoop. So, by measuring the distance from the border of the mandible to the inferior border of the mental foramen, we can classify the bone resorption. In class 1, usually this height, the residual ridge should be 3 times the height from the inferior border of the mandible to the mental foramen. So this is an ideal ridge, which is a class 1. If it is less than that, it is class 2, and if it is very severe, it is class 3 ridge resorption. Now coming to the last phase, that is the treatment plan. After diagnosis, we have collected all the information and we have to do the treatment plan. A treatment plan is the process of matching possible treatment options with the patient's need and systematically arranging the treatment in order of priority. So first step in treatment planning is adjunctive care, such as we should eliminate any infection of on pathology. If there are abused tissue, conditioning of the tissues should be done by asking the patient to not to wear the ill-fitting denture or by realigning his existing dentures with tissue conditioners or soft liners. If any pathology is associated with poor nutrition, patient should be advised to take multivitamins, antioxidants, and a good balanced diet. If there are any undercuts, exostosis, or insufficient intra space, then in such cases, or bony spicules, then in such cases, pre-prosthetic surgeries need to be planned beforehand. And following which, the definitive prosthodontic treatment plan is given. In case of completely dentulous patient, we may prescribe a conventional complete denture or an implant supported fixed or removable complete denture. Or if there are a couple of teeth present, we may also consider retaining those teeth and giving a tooth supported oval denture. Now, lastly, before concluding this lecture, I would like to pick your interest in something which is called as a Prosthodontic Diagnostic Index, which was designed by the American College of Prosthodontics. So, this is an index which classifies or puts the patient into four categories based on the various diagnostic criteria or diagnostic steps that were taken beforehand. So depending upon the height of the mandibular bone, depending upon the maxillomandibular relationship, whether it is class 1, class 2, class 3, depending upon the ridge morphology of the maxilla, whether there is has been resorption of the buccal vestibule, the posterior maxilla, whether there has been resorption of the anterior or the labial vestibule or the premaxilla, and depending on the muscular attachment, whether muscular attachments are too close to the crest of the ridge or they are far away from the crest of the ridge. The patient is divided into four categories. Class 1 is a patient who has ideal ridges for the denture construction and has the greatest chances of success. Class 2 is patient's alveolar ridges are moderately compromised but still a good fit for the success of a complete denture. Class 3 and Class 4 have severely compromised or substantially compromised residual alveolar ridges, and they may require adjunctive care or pre-prosthetic surgeries or addressal of the systemic condition before a complete denture can be fabricated. So this brings us to the end of a long lecture, and I hope this was helpful and beneficial to all. And this is the Prosthodontic Diagnostic Index or the checklist which I was mentioning. So based on these four diagnostic criteria, the complete edentulism is divided into four categories, as I just mentioned. So that brings us to the end of our lecture. This is the reading list. So please go through this, and thank you for your time and patience.